Morning, everybody. I'm Paul. Pleased to meet you. So I work for KPMG. I run KPMG's public sector analytics business. My background is that I'm 50, been around quite a long time. Spent some years in a trust, some years on Whitehall in policy and strategy. Went into the software industry, grew a couple of startups, took them to acquisition. I was the analytics director at EMIS for a little while, and I've been at KPMG for 3 years. So some of the things that I'm going to talk about hopefully will resonate with some of you who may be on similar kind of journeys. I think I'll be giving some examples of things I've seen in the NHS. The first thing to say is that the deck that I've put together has been compiled on the basis of lots of work that KPMG have been doing internationally. So the similar stories I'm going to tell would apply in Iceland, Israel, the US, anywhere that's trying to think about developing a holistic response to the challenges that they face in looking after their population. Because essentially, we all want to live healthier, longer lives, and fewer of us want to have any contact with the secondary care system. And you can't really do that unless those who are providing services are using data in the most effective way. So here's our level set, right? So we all know, many of you will be in the software industry, and you'll be talking about the return on investment from your products. You'll be saying, look, if you take our product or our service, you can improve the safety, quality, and cost effectiveness of services. And one of the great things about the Zuri video that we just watched is the way that it aligns a technical solution with a clear challenge that a care system faces. And you could very easily see how a solution like Zuri's could become the oxygen of an accountable care organisation looking after a population. That's the kind of challenge that we're trying to address in quite a large way. So in KPMG, I couldn't really function without the benefit of some of the partners that I work with. And so some of these stories I'm going to tell you have been developed in conjunction with Microsoft. I've got lots of partners who work in lots of different areas of business. In fact, I've got my lovely friends from IBM who are sat over at the table, and you're going to hear from Mark Lovely Davies later on about the work that they've been doing too. But I guess the level set is the same. So this causes challenges for our staff in the care system, not just those who are employed in public-facing elements of that, but also the third sector, charities, also private industry. And if we're thinking about ourselves as software, service, solution, technology providers, we have to think about ourselves as part of that family. And we have to be cognizant of the challenges staff face. So I'm sure we'll see lots of presentations that talk about the benefits of robot process automation, for example, and the way you can augment the work of staff by using technology in that way. But there are some fundamental staffing challenges we face. We heard about a fundamental bed challenge earlier on this morning. We've also got a fundamental staffing challenge. One way to think about that is that we have too few staff to fill the vacancies that we have. Another way of thinking about that is that we have too few staff to deliver a 20th century care paradigm. Actually, if we thought about a 21st century care paradigm, where we were dividing up tasks, we were doing them in the most appropriate way, then access to a digital workforce might be our biggest area of challenge, but also our biggest area of opportunity. So we need to do something different. So we have a rainbow of things that are occupying people's minds at the moment. And this rainbow of challenges really boils down to developing integrated care services that are focused on looking after the needs of a whole population by integrating care services in lots of different settings. And that is rock hard. That's a technical term. So you can't develop a patient-centered approach to care without the effective use of data. What is my population? What are their challenges? How do they consume services? What do I predict the situation is going to look like? What budget do I need? How do I report to my regulator for the performance of the services that I provide? How do I secure the outcomes that I want to secure for those populations? Those are the sorts of conversations that boards of integrated care organizations have all around the world. And successful software vendors and digital solution providers are really aligned to that conversation and using data to offer new insight into the design of services. I'm not going to walk all around the rainbow, but I think that the take-home message from that is that there are probably 3 or 4 things that care organizations are trying to do. They're trying to shift more activity into the community, so do more things closer to home. How do you do that? If you can figure out how to do it, then that's going to provide safe, quality, and cost-effective care for your population. It's going to increase health and well-being, and it's going to stop you being a sickness response service and be a health service. Second thing is probably, how do you remove duplication? Because there are lots of services providing the same thing. So it's tempting to think about IT as a cost. And we talked about earlier on the budget that's available in the NHS for technology, 1.5% or something around that. Actually, the opportunity to use technology is in the other 98 and a bit percent. And actually, the threat is in there as well. So if you can use data to understand how to optimize that care system and use that investment that goes into the 98.5%, you actually get a bigger return from your 1.5%. So if you think about electronic prescribing as an example, electronic prescribing has a cost associated with software and implementation. It has a much greater cost associated with transformation, changing the way that nurses work. It's difficult. It takes time, requires a lot of collaboration. But actually, if you do it, that investment is unlocked and pays dividends. And you can't do that unless you effectively use data. So technology can help. So there's lots of these kind of from and to type pictures that you'll often see. My from and to picture is the EHR paradigm. So people get beguiled with, I need to swap out my EHR and buy a new EHR. What we're seeing in emerging economies, where they're trying to implement universal healthcare coverage, places as big as India and as small as Indonesia, is a leapfrogging of that conventional mentality that I need a big, hairy EMR in the middle of my acute and everything should be clustered around it. What we're seeing is a greater focus on treating the patient as a consumer, using our understanding of how patients want to consume services to drive their channel selection, so they use the most appropriate services. And that doesn't always mean coming into a hospital. And so in that context, we're seeing CIOs far more beguiled with analytics and insights, using unstructured data and using big data. So I had one night in hospital when I was 16. That's the secondary care system's sole knowledge about me. I'm 50 now. Mrs. Henderson's nectar card will tell you I like red wine and cheese. So actually, if you analyze that data, the next time the secondary care system sees me, I'll probably have type 2 diabetes unless I do something about it. So you have to use non-traditional data sources to really understand how patients are consuming services. And the good news for all of you is that the emerging technologies are helping us address those challenges by using breakthrough technologies to provide breakthrough capabilities in the care system. I'm just going to talk a little bit about the Internet of Things. So it's tempting to think about the Internet of Things as a technical thing, which of course it is. But actually, if you think about it in the context of the challenges we face in our care system and relate that back to some of the things that I've just spoken about, actually, the house and the person are probably the new frontier of health and social care IT. And that's because in our house, it's wildly different from the houses that our parents and our grandparents lived in. Many of you, so my nana had one of those things around the neck, the red button, press the red button, you fall over. Assuming you don't knock yourself out, press the red button. Somebody will ring you up, somebody will come to your house. Actually, that's a 20th century thing. It's useful. But think about, reimagine that in the light of what we know about a 21st century life, about tech and about use of data. So in a new house, you might have a whole bunch of commercially available devices. You might have a digital fridge that might do your reordering for you. You might have Alexa. You might have controlled heating through Hive or whatever the equivalent is that you might use over here. You might have a range of sensors from the commercial world, not necessarily clinically validated, but an opportunity to extend the boundary of your care system into somebody's house. Alongside that, you might have a whole set of clinical devices. We heard earlier on about the development of apps. Equally, GPs in the UK and elsewhere have been doing social prescribing for a while. They've been prescribing blood pressure cuffs, digital scales. Nokia acquired Withings quite a while ago to think about how we can use clinical grade equipment in the home to improve care. A firm called Oxy Health just registered, I think, the first patent for a digital camera that helps detect a patient's vital signs just by taking a picture of them and thereby extending the opportunities to use wearables in the home. So the home is going to be very different. What happens when you connect that home via apps into a care system? You extend the boundary of the care system, you extend the workflow, you extend the opportunity to look after people more effectively in their homes. Slight challenge in this image is the proliferation of apps. So some of you might think about, well, we have an app for that, we have a solution for that. The challenge maybe we face is how do we build a personal healthcare, a domestic healthcare platform that simplifies this for the patient, connects the care system as a whole, and provides a mechanism for deployment of those apps. So some big issues that we need to think about before we get to this kind of point. Equally, the care system needs to connect more effectively with itself. So one of the other levers you can pull to improve the efficiency of care systems is to rationalize sets of services, probably in the back office, the middle office, and the front office. So without looking through all the detail of the slides, thinking about, okay, what happens if we have an integrated care organization comprising many partners who were previously disconnected and we connect them together? Well, the first thing that you would do if you were in the mergers and acquisitions world and you were a private sector business is you'd look at rationalizing some of the services. You look at rationalizing back office, HR, payroll, those kinds of things. Then the next thing you might look at is a whole range of middle office solutions that you've implemented that may be disconnected, duplicatory, or whatever. One of my reflections and spending a lot of time in the NHS is that everybody has a rostering system. There's one or two vendors that lead the market in that space. Very few have implemented it effectively. And I know this to be the case because the data tells me that too many NHS services are not provided efficiently. We over-provide outpatient slots. We over-provide outpatient services. We don't align our waiting list to our theatre lists so that we can optimize using rostering the deployment of staff. So there's a middle office space. And we've already heard this morning about treating their patients as a consumer. Saw a fantastic app called Weightless by a company that spun out of Greenwich University a couple of years ago. And all they're doing, it's quite complicated, but they're taking A&E data from lots of different places, sticking it in an app so you can choose whether the most optimal way of getting unscheduled care is to go to an A&E. And we all know the answer is that's sometimes the case. It's not always the case. So the challenge is, how does the system connect with itself? And how does that data create a golden thread that goes all the way from the front office or the home right through to the back office? But if you can do that, then you've got lots of opportunities. So we've heard about the sustainability and transformation footprints in the UK. So throw a mat around a population, organize your services around the needs of that population and deliver the outcomes that they want. There are other countries that have done that. I'm always interested when US vendors talk to us about accountable care organizations because they invented it, and yet it's the health economy that spends the most per capita on care. Very interested in what's happening in Israel. In Israel, they have a greater focus on community care, so much so actually that if you're a community medic, you get paid more than if you're a hospital medic. So you imagine that happening in the UK? You imagine the orthopod getting paid less than the person who runs the community services? So interesting, but nevertheless, a population health challenge. So what is my population like? So market segmentation, where are my highest users? How can I organize care around the needs of the citizen? But how do I think about the real outcome that I'm trying to buy? So interestingly, The bottom right, this is the way they do it in New York State. So in New York State, they reformed their Medicare, Medicaid program, which is basically their publicly funded services. And they decided they were going to have a set of cascading performance indicators they would use in order to demonstrate whether they were getting value for money for their investment in care in New York. Getting a set of cascading indicators is really difficult. The temptation is to make it out of input measures or standards like 4-hour waits, 2-week cancer waits, because you're trying to think about improving access to services. They thought about, well, actually, if the care system works effectively, there shouldn't be any complications in patient care. So actually, we're going to reward smooth running, and we're going to kind of, I'm sure there's a better word for this, but penalize poor running. And they came up with this concept of potentially avoidable complications in patient care. So where a patient should have had appropriate treatment in the community, but actually presented in secondary care, that's a bad thing. So we should disincentivize that from happening. So those of you who work in the data space, if you are thinking about outcomes and you are thinking about partnerships with charities like ICHOM who look at that kind of thing, value-based healthcare, that's the more appropriate use of data, and that's where the market is heading. So these are a couple of things that we do over in KPMG. Other technologies, other solutions are available. Across the bottom here, this is our Imperial University Data Observatory, or as my kids call it, the room with the big tellies. So if we were thinking about the big tellies, what we're trying to achieve here is to move from a system-wide view of a devolved economy right through to a hospital ward on the right-hand side. So if you're thinking about a devolved economy, or you're thinking about an island economy, you've got a set of challenges to face and a set of levers that you can pull. This happens to be from Glasgow as part of their devolution deal. What Glasgow were trying to do is think about half a dozen domains of interconnected public services. So when I think about healthcare in Glasgow, I don't just think about the care system in Glasgow. I think about how we can use transport, education, the justice system as levers we can pull to improve care. And then I think about how do I then model those interventions so that I can be sure the business case for the change stacks up. So there's always a top line, which is the line of doom, which says population's growing, clinical acuity is growing, people are living older, longer, with more comorbidities, consuming more services, costs are only ever going to go one way, so you always have a line of doom across the top. And the trick is how you then bend it. So how do you get to a situation where you're providing more effective services that bend that cost? What does that mean for the populations that you serve? In this case, looking at the Isle of Wight. Seems quite sensible on the Isle of Wight to move some services around. Looks quite good on a spreadsheet. But when you look at it on a map and you factor in the travel costs that patients face, and you factor in the island premium that's caused by moving patients from one place to another without recognizing there's a patch of water in between, it suddenly becomes less attractive an idea. And then as you go over towards the right-hand side, you're drawing a direct line between the system at this side and operating theatres on this side, using AI and machine learning to understand how some of these levers which you're going to pull over 20 years will actually impact your operating tomorrow. So just a final couple of slides about AI. So there are lots of opportunities to use artificial intelligence and to use robot process automation and some of those things. The image on the right-hand side is a data science view of a set of algorithms we put together to optimize the flow of patients through a hospital. And the important thing is less the risk that the patient has in that flow being interrupted, and more the levers you can pull to prevent that flow from being interrupted. So when you think about patients presenting in A&E, you probably could think about whether they were going to bust the length of stay for the thing they were going to be admitted with. And you could probably think about why that would be. The temptation is to think about that in a clinical sense. Fractured neck of femur, fix the fractured neck of femur, patient out. But actually, if you don't plan for discharge, as you're making the decision to admit, they're probably not going to go out on time. And if they're presenting with fractured neck of femur, but they're a patient with mental health issues or domiciliary care issues, again, they're not going to get out in time. And therefore, you need to use AI and machine learning to think about the patient in the round. And solution vendors that come up with answers to that problem are the ones that are going to be using data to win in the market because they'll be driving the most benefit for patients. Putting data into a system has historically been a right royal pain in the neck. So a patient comes to see you and you say, yeah, just stop talking a minute, I'm looking for the thing in the pick list. So we're seeing health economies flipping over that, leapfrogging that challenge that exists in conventional EMRs, and talking being the new typing. So this is my mate Andy Wiley, and I recorded a conversation with him. While that conversation was being recorded in real time, it was being clinically coded because he was using natural language processing to listen to the conversation and pull out the salient points. It was also looking at the quality of the conversation. How much time did the care worker spend talking? How much time did the patient spend talking? What was the patient's mood at the start? What was the patient's mood at the end? Is that really the right patient? Using authentication and facial recognition to look at who that patient is without necessarily requiring the use of a smart card. So thinking about these new and emerging technologies in the construct of clinical workflow is going to be hugely important. I reckon I can't quite make sense of the timer there. This is 1908, but I think I'm done, am I? Pretty much. So my final kind of, thank you very much for listening, but my final 3 take-home messages, because I work for KPMG, there's always 3 things. Right, so if you ask a friend from KPMG to go to the chippy, you want fish and chips, they say, what's the 3rd thing? Can I have gravy? So there are 3 things. So there are huge opportunities to improve health and well-being by sharing and analysing data across care systems. So thinking less about the provision of point solutions to point problems, but thinking about your whole digital vision, your whole data vision across integrated sets of organizations. Technology is going to make life easier at last. So sometimes, those first early technologies, they don't quite work as you expected. But we've seen some good examples of how technology is more mature and is getting to market faster. And that's causing a cultural receptiveness to new technology in the market that probably wasn't there 10 years ago, and many in this room will benefit from that. I think a third slight area of caution is to think about the ethical considerations in relation to data sharing and use of AI and ML, and using AI and ML to provide universal health coverage of a consistently high standard rather than as a means of rationing. So there are a whole bunch of complicated issues to address to get the best use of data. But if we use data in the most appropriate way, it can be a fantastic enabler of population health, and it can enable us all to live longer, healthier, happier lives. Thanks very much.